Thank you, Steve. Good morning. It's a pleasure to be here, and I want to thank ICOS for the opportunity to participate in this COVID-19 Cardio-Oncology series. My name is Diego Sadler. I'm the section head of Cardio-Oncology at the Cleveland Clinic, Florida. I chair the Cardio-Oncology Committee of the Florida chapter of the American College of Cardiology, and I also work with the ACC Leadership Council and Advocacy Work Group. So today we're going to discuss some aspects of the impact of COVID-19 in our practices in our patient care. All right, so let me see. Oh, it's kind of stuck. Hold on a second. All right. So starting with this slide from the Johns Hopkins Coronavirus Resource Center, as we all know, the impact of COVID-19 in our lives and practices has been massive. There are currently 38 million global cases, led by the United States with 7.8 million cases of COVID-19, India 7 million, Brazil more than 5 million, and so forth. As you can notice in this map in red, the impact is worldwide, and the hotspots of the pandemic have migrated from the beginning in Wuhan, China, then moving to Europe early on, the United States, Latin America, and currently the areas with the most cases are based in North America, South America, and Asia, with a rapid resurgence in Europe. And as you can see in the right side of the slide, also the mortality is significant, more than 1 million deaths already, with currently almost 218,000 deaths in the United States, more than 150,000 in Brazil, and so forth. This slide shows the progression of cases and kind of shows that this has not slowed down or decreased in spite of us being in this pandemic currently for 7 months already. As you can see in orange, the United States continues to have a rising number of cases. India in green has had a significant increase as well, particularly over the last few months. And then Brazil in pink has consistently been one of the top affected cases, countries in cases throughout the world. And this slide, I mean, I think it's significant because it shows our struggles. It shows our struggles, again, starting with the United States in orange initially, with that big peak and massive number of cases in New York City, getting the 30,000 cases per day, then kind of plateaued by June. Then we had this big spike in July and August, getting more than 60,000 cases a day, then went down, and it was going up again, and we're hitting again the average of 50,000 cases a day. Similarly, you can see in India with a massive late surge now seems to have labeled off a little bit, and something similar with Brazil. This probably being a reflection of our inability to get a hold of this pandemic, related to multiple issues, probably related to lack of availability for worldwide testing, contact tracing, national directed healthcare policies with a clear direction how to deal with this, and of course the limitations with very limited therapeutic arsenal to reduce morbidity and mortality, and still on the woods with a vaccination that hopefully will become a reality in some places in the next 3 to 6 months. We can see the case fatality ratio here in terms of percentage. Mortality this time is highest in Mexico with 10% mortality of the reported cases, and then goes all the way down to 1.5% of reported cases in India. And you see the United States somewhere in the 2.8%, Brazil 3%, and it's varied. United Kingdom at 7%. And again, some of these mortalities, for instance, in Europe and United States, are significantly impacted for the much higher earlier mortality than the current numbers. But still, overall, I would say 2 to 3% is the overall number of mortality per reported cases in the United States. And probably more significant in terms of impacting populations is the deaths per 100,000 population. And in this particular category, Peru leads the pack with 103 per 100,000. Then you see Peru, Brazil, Ecuador, Mexico, 4 Latin American countries in the highest numbers, and also Spain, the United States, and United Kingdom following close behind. So with this background, I just wanted to mention start with some data from a survey that we did with a collaborative network. Briefly, we have this wonderful collaborative network with a goal of improving awareness, education, and access to care for cardiologists and oncologists, both in the academic and the private practice setting. And we have been working with providers and cardiologists and oncologists from 17 state chapters of the United States, 7 ASCO chapters, and 10 ICOS chapters, international chapters from ASCO. We also, in the next few weeks, will invite, and we're looking forward to have more participants working in our network for our future projects, and with the goal of improving awareness and access to care of cardio-oncology in the community. So with this background, so we know that the reallocation of resources during the COVID-19 pandemic has resulted in delays in care delivery to patients with cardiovascular disease and cancer. And the ability or the impact on healthcare providers to provide optimal care was not formally evaluated. How did that affect our practices? So we wanted to look through interview or getting responses from providers, the impact on resources reallocation on scheduling, testing, elective procedures, telemedicine, use of new COVID-19 therapies, and providers' opinions on healthcare policies among cardiology and oncology practitioners. So we did an electronic survey conducted by this collaborative network, as I mentioned, with regional and state chapters of the ACC, ASCO, and ICOS. We had 1,415 providers participate in this survey, 986 cardiologists, 306 oncologists, and 118 trainees in internal medicine that were working in similar institutions and also responded to this survey. One first difference was 63% of oncologists reported some delay or cancellation or modification of treatments. 92% of cardiologists, almost all of them, reported also cancellation or a deferral of elective treatments. 46% of cardiologists and only 25% of oncologists modified the scope of practice. That means redeployed to act as frontline caregivers in the ER setting or ICU setting. Academic physicians felt better supplied with PPE than private practice physicians, 74 versus 67%. That was statistically significant. The use of telemedicine was almost universally adopted early on, and was mostly in the United States, 88%, a little less in Europe, 81%, and Latin America, 64%. 95% of all groups supported more active leadership and involvement from their professional medical societies. Just please keep in mind that this was an early survey done in late March and the first 2 weeks of April. So really very early on during this pandemic, when we were just trying to understand what was going on and what the impact on our practices was. So this map shows the geographic distribution of our participants, and they were mostly from North America, United States, and Canada, with almost 200 participants from Latin America and almost 100 from Europe. Within the United States, Florida, Illinois, and California were the 3 states that provided the most answers to this survey. So as you can see in this slide, rescheduling outpatient appointments, cancellation of most elective procedures, and decreased utilization of echo, CT, PET, MR, or other imaging modalities was highly prevalent in the United States, Europe, and Latin America. So when we asked about, does your institution provide proper protection to all healthcare workers to the level they are exposed to, the level of risk. There was a little better protection reported by the practitioners in the United States when compared to Europe and Latin America. However, you see, it was far from 100%, and at least 30% or 35% of providers in different locations did not feel that they had proper protection equipment from their institutions. In terms of access to COVID-19, again, was about 75% in the United States and in lower in Europe and Latin America. Again, we're talking about very early on the pandemic, where testing was really very difficult to get by. In terms of, we asked about what was the utilization of novel therapies. And again, March and April, we didn't know what was going to work, what will not work. To a great degree, we still don't know, unfortunately. We have some answers, like with IV steroids, some data on remdesivir. So we used remdesivir as one of the most promising antiviral therapies available at that time. And the utilization rate was quite low in low locations. It was between 25 and 30% in the United States, depending if you talk to oncologists or cardiologists or private practice versus academic, little higher in academic than private practice, and lower in Europe and Latin America. But the overall rate of utilization was quite low across the board, and even lower for tocilizumab, an IL-6 blocking agent utilized or proposed as treatment for the COVID-19 related myocarditis, also for the cytokine release syndrome that plays such a significant role in inflammation and bad outcomes in the second stage of the disease. As you can see, the use was very low. I think it was 16% in the United States versus 11 and 9% in Europe and Latin America. So this is just highlighting what we mentioned, that oncologists were redeployed only 25% of the times compared to cardiologists. And that has probably to do to cancer treatment was interrupted to a much lesser extent than cardiology treatment because of the nature. And also cardiologists were more frequently redeployed to first line because they're more experience and knowledge in critical care management, ICU management, as well as during this early stage of the pandemic. There were a lot of cancellations of cardiac surgeries, interventional, structural, EP, all that was down for a while until it gradually restarted in the United States, Europe, and other locations. In terms of the use of telemedicine, as mentioned, was an early adoption in these three locations, a little higher in Europe than in the United States and Europe and Latin America. But on the other hand, the redeployment or asked to reduce the specialized practice was much more prevalent in Europe and Latin America than the United States. We probably heard the personal story of redeployment by Arjun Ghosh, Dr. Ghosh from London, who nicely reported on the NHS redeployment strategy in the United Kingdom. In terms of institutional support, we see it was a little higher in the United States, 74% versus 60 and 61% in the other locations. I just mentioned the low utilization rate for tocilizumab and remdesivir. And I wanted to focus a little bit in the last 2 points. And in terms of policy, this is a topic poorly represented in the medical literature that's not regularly looked into. And we asked, in your opinion, should there be a government mandate nationwide quarantine or lockdown to slow down the propagation and transmission of COVID-19? Again, we've moved beyond that stage. This was March and early. Remarkably, 85% in the United States and 92 and 92% in Europe and Latin America were strongly in favor. And I see this as we moved on, a claim or a call from practitioners all over the world to have national coordinated policies for more efficient response to this uncontrolled pandemic. And similarly, when we ask, should medical professional organizations take a more active role and have more influence in official healthcare policy and government policy during a major healthcare crisis? And this one was universal agreement, 95% in the United States, Latin America, and Europe, cardiologists, oncologists, academic, private practice, everyone by a consistent 95% said, yes, we want our professional medical organizations to be heavily involved, to have a voice, and probably be able to bring to the table data-driven policies that can have an impact and hopefully have make a difference in outcomes when physicians have a voice in planification and management of crisis and during a public health emergency. So moving on, looking at the impact of COVID-19 in the cardio-oncology population, I just want to start with some of the JCC Cardio-Oncology NICE review by Dr. Ganatra and co-workers, and where they state that patients with cancer or cardiovascular disease are risk for both acquiring COVID-19 infection and suffering worse outcomes compared to the general population. And early reports from China show that the COVID-19 mortality rate was highest among patients with cardiovascular disease, 13%, and a recent WHO report shows also high mortality, more than 7% among cancer patients. And recent CDC data show that amongst all those patients with COVID-19, those with cardiovascular disease present 9% of all infected patients. However, when we look at the subgroup requiring intensive care unit, then 29% have previously existing or preconditioned with cardiovascular disease. Therefore, we see that our cardiovascular disease pre-existing patients are overrepresented amongst those with poor outcomes. So as we know, elevated troponin is associated with worse outcomes and increased mortality. ACE2 binds to the SARS-CoV-2 spike and is widely expressed in heart and lungs. Mechanisms involve cardiovascular damage in the CRS triggered by exaggerated response to T helper cells and hypoxemia from respiratory insufficiency. I want to briefly mention these two recent studies published in JAMA Cardiology on July 27, 2020 from Germany. One with 100 consecutive CMR patients recently recovered from COVID-19, and there was a high prevalence of inflammation in 60% of these patients. In the same issue, there was another study looking at autopsies of elderly patients who had been swabbed positive for COVID-19, and amongst those 39 elderly patients who had autopsies, in 60% of them had viral load in myocardial tissue. So we know that inflammation, direct myocardial injury, and hypoxemic respiratory failure play a significant role in the pathophysiology of this disease. From our Brazilian colleagues, this slide shows the incidence of thrombotic events. We know that not only pulmonary thrombotic phenomena and DVT and PE are present, but also arterial thrombotic events are a concern. And recent studies presented, published in JACC, show the beneficial impact of anticoagulation in some of these patients. So this slide from the ESC clearly shows the some of the mechanisms and how the presence of hypotension, inflammation, cytokine release storm, thrombosis, vasculitis, all result in a significant derangement with a resultant elevation of troponins, D-dimer, IL-6, and T-proBNP, platelets going up and down, lymphopenia, with the clinical findings we're all familiar with coronary disease, STEMIs and non-STEMIs, also a pseudo-MI presentation with myocarditis, Takotsubo cardiomyopathy, heart failure with HFpEF and HFrEF, and also evolving some cases of cardiogenic shock. Management, as we all know, with pressors, ventilation, optimization of hemoglobin, etc. I just wanted to point in this slide the use of ECMO, VV and VA ECMO. In our institution in Cleveland Clinic, Florida, we've had many cases of critically ill patients with severe refractory hypoxemia to ventilation, to ventilator support that had really good outcomes with VV ECMO, and so our group with a consortium of heart failure physicians have reported this data, and ECMO seems to play a significant role in the most critically ill patients. So this is an elegant slide from Dr. Herman in the recent presentation of the great Memorial Sloan Kettering series that goes on once a month. And this is from a single center case series study from Wuhan, China, early on during the pandemic, and about the risk stratification by cardiovascular status. And you can see that in this case series, patients who did not have cardiovascular disease and troponins were normal had a mortality of 7%, then that doubled to more than 13% when there was cardiovascular disease in spite of normal troponins. Then when they had just troponin elevation without previous cardiovascular disease, mortality was 37%. And with both cardiovascular disease and elevation of troponins, that almost 70% mortality. So and similarly, you can see the dramatic impact on survival and prognosis of common biomarkers utilized in our clinical practice. You can see the blue lines in the bottom among survivors who had normal D-dimers, IL-6, and high sensitive troponin. They really did very well, as opposed to those who had elevation of any of these markers, not to mention all of them. You see D-dimer, IL-6, and troponins were associated with really poor prognosis and mortality. So zooming back in these JAMA Cardiology July papers, this first one in outcomes of cardiovascular magnetic resonance imaging in patients recently recovered from coronavirus. These were 100 consecutive patients. 2/3 of them recovered as outpatients, 1/3 of them had been hospitalized. And they looked at T1, T2, and late gadolinium enhancement. And 78% of the patients who had recovered from COVID had any one of these cardiac abnormalities, and 60% had signs of inflammation with prolonged T2 in absence of LGE. So this suggests from this study that myocardial inflammation with subtle and not so subtle CMR abnormalities are highly prevalent in the COVID-19. The clinical significance is still unclear, and who should be referred for CMR is still unclear. In this same issue in JAMA Cardiology from another German study, they looked at 39 consecutive autopsy cases. This was a very early population. The mean age was 85 years old. And they looked at, all of them had been nasopharyngeal COVID-19 PCR positive during their disease process. And then they looked at what was the prevalence of virus in myocardial tissue in their autopsies, and 61% of them had significant viral load in their myocardium. Surprisingly, they looked at inflammatory infiltrates and they didn't see much. So they concluded that there's a high direct myocardial infection and viral load, but no significant inflammation. And probably in contradiction to the other CMR paper published in the same study. And to me, this just highlights so much more. We still have to learn and understand about mechanisms and impact in cardiovascular medicine in all aspects of this disease. So in terms of the outcome, yes?
Diego?
Yes.
Hi, this is Dan. Thanks so much for your great presentation. I did want to touch base on the last two slides that you just showed.
Okay.
So I think one of the general assumptions is that if you have some gadolinium uptake on an MRI, that equals myocarditis. And I really don't think that is validated in a broad population of patients. And I know that the people that are MRI aficionados would probably argue with that point, but that has just not been my experience, that the gadolinium enhancement in some pattern, whatever pattern, is not tantamount to myocarditis. So the two differences in those slides that you showed is that if from an MRI-based study, you have all these patients that have an inflammatory infiltrate from COVID, and then you have an autopsy that shows that they have viral particles, I guess, in the myocardium, but no inflammation. Really, to me, it tells me the limitations of MRI in terms of detecting the true presence of myocarditis. So I think that you can't assume that gadolinium uptake equals myocarditis. That would be the main point.
Thank you, Dan. No, I totally agree. They still made a point that many patients had just T2 prolongation without late gadolinium enhancement, trying to point that as a sign of inflammation. But I agree, the data in MRI is, I'm not an MRI expert either, but talking to our MRI and also from what we've heard in the ICI myocarditis MRI data, the data is still confusing in terms of true positive, different diagnostic criteria, and the significance in prognosis that, as opposed to strain, MRI doesn't seem to have that clear prognostic signal in some forms of myocarditis. But yeah, thank you for the comment.
Well, and I would add to what you just said about the T2 measurements. Now, you're not a self-proclaimed MRI expert, neither am I, but I would say that I have watched them trace T2 measurements, and I've looked at the reports, and I've looked at the original data in a number of patients, and to me, that finding is subject to significant variation based on the interpreter. And then more importantly, if we just order an MRI clinically here at WashU, they won't report on T2 findings. They probably don't even measure them, but they certainly don't report on them. So if we order 100 MRIs, I would say that T2 measurements are only present on the report maybe under 10%, probably less than 5%. And so how can you say that a test that it is done relatively routinely, where the measurement is done so rarely in a discoverable way, how could that really be all that meaningful? It's like when we try to assign so much significance to strain, but if you only reported strain on 5 out of 100 echoes, how useful is that measurement? So I think that, it's one thing to say in the perfect world, some measurement, may indicate a problem, but in the actual care of patients, those measurements are not done reliably.
Yes, thank you. Yeah, I totally agree. In other institutions also, LG is reported routinely, but T2 is not part of the routine report. I totally agree, and thank you for the comment.
Yeah, no, I wasn't trying to mess up your mojo there, but I couldn't.
No, you're absolutely right. You're absolutely right. Thanks. So, and this also from Jörg Hermann's MSK Memorial Sloan Kettering presentation, looking at the data on the impact of cancer in bad outcomes in the COVID-19 population. So you can see that patients with metastatic cancer had significantly more deaths, ICU, hospitalizations, and clinical severe disease when compared to non-metastatic cancer and patients without cancer. You see these three curves in green, orange, and blue. And when they looked at this cohort of patients at Memorial Sloan Kettering, 39% of them had severe course and hematological malignancies, particularly leukemias and myelomas, and thoracic malignancies seem to be associated to worse outcomes in this population. Got stuck again. Okay, so in our COVID-19 in cardio-oncology, We have to be aware that comorbidities and age matter in terms of worse prognosis. Previous cardiovascular risk factors matter. Pre-existing cardiovascular disease makes a big difference. Malignancies, particularly hematological malignancies like leukemias and multiple myeloma and thoracic, are associated with worse outcomes. Reports also of immune checkpoint inhibitors are associated with worse outcomes in the cardio-oncology population. We know that inflammation, thrombosis, and myocardial injury are mechanisms for unfavorable evolution. In this slide from Sergio Ganatra from JACC Cardio-Oncology earlier this year, with potential mechanisms associated with cardiovascular injury, you can see that how this lung injury and cardiovascular injury can affect patients, and cancer patients who are also undergoing surgery, chemotherapy, immunotherapy, or targeted therapies. We also see the importance of these cardiac risk factors, hypertension, diabetes, and pre-existing cardiovascular disease. And if you look at these little tables close to the bottom of the slide, you see that severe outcomes were associated to coronary disease, hypertension, diabetes, and cancer. And the other one, the little table in colors, mortality was higher in patients with cardiovascular disease, diabetes, hypertension, and cancer compared to those without comorbidities. And they had this workflow for patients with coronary disease that when coronary disease is stable, starting with considerations for telehealth and remote platforms, consideration for postponement of elective procedures, and education about risk of COVID-19 and precautions. When they have active cardiovascular symptoms, obviously there are suspicious symptoms of exposure, go through all the precautions in COVID-19 that by now we're all very familiar with, and routine cardiovascular management as per guidelines. For the cancer patients, consideration for telehealth for stable patients, continuation of anti-neoplastic therapy up to discussion of risk benefit, and also for patients who are high risk, particularly, for instance, stem cell transplant patients, consideration for self-quarantine. In terms of the modified cardiac imaging surveillance of cancer patients with COVID-19, this very good review or paper by Dinesh Temadarantan in the Toronto group at JCC Cardio-Oncology, proposing striking a balance between early detection and risk of COVID-19 infection, deferring baseline testing for anthracyclines and trastuzumab for what's considered low-risk patients by ASCO risk stratification, surveillance during treatment, delaying routine imaging prior to starting treatment in asymptomatic patients with low-dose anthracyclines, and switching to every 6 and 12 months as opposed to every 3 months for low-risk asymptomatic trastuzumab and HER2 targeted therapies patients, and twice a year in the first year for metastatic HER2. And of course, deferring long-term surveillance after cancer treatment for a time when the pandemic is hopefully over. And here they go in a little more detail. So for pre-treatment for anthracyclines, for baseline, only do imaging prior to initiation of therapy, and those with significant history of previous cardiovascular structure disease, cardiomyopathies, arrhythmias, valvular heart disease, those who are symptomatic, those with 2 or more cardiac risk factors, or those who are expected to undergo high-dose anthracyclines. Similar criteria for trastuzumab, do baseline imaging only in those who are high risk, pre-existing disease, risk factor, symptomatic, or previous exposure to anthracyclines. And they go for similar algorithms for during treatment and post-treatment. And from the Memorial Sloan Kettering group, they looked at the existing guidelines by AAC, the National Comprehensive Cancer Network, and ASCO, and essentially these are repetitive treatment before, during, and after treatment, trying to target imaging protocols and more aggressive surveillance for those who are high risk or symptomatic. And high risk, as we know, are those with multiple risk factors, such as hypertension, diabetes, dyslipidemia, obesity, age more than 60, compromised cardiac function with borderline or low EF, previously existing structural heart disease by CAD, valve heart disease, or arrhythmias, and of course, prior exposure to cardiotoxic therapies, particularly anthracyclines and radiation therapy. So finally, I'm going to briefly comment on this because, you know, this has been previously presented. And so, but I think this is a very important document by ICOS, led by Dr. Lenihan and also Dr. Herman, Tom Neelan, and most of the leaders in our field who have led us in establishing parameters, guidelines, and working flows and algorithms. So this baseline slide will look at the hematology oncology patient before, during, and after cancer therapy, identifying cardiovascular risk, and focusing in risk stratification for cardiovascular risk, cancer risk, and COVID-19 risk. For cardiac risk, those with low risk, continuation and starting cardiovascular treatment, there's no room for interruption of treatment. Those with low risk may be the possibility of cancellation of deferring surveillance. Similarly, those with high cancer risk, continuation of cancer therapy, and those with low risk, consideration for modifying cancer therapy in type of administration and timing. And in terms of the COVID risk, high risk, either for high risk for disease or geographic high risk, minimize hospital and clinic visits, and low high risk, continuation of clinic visits with all the current precautions. We also established a workflow for the 3 phases of preparation, execution, and maintenance. And again, there's a gradient of aggressiveness. And obviously with acute emergencies or severe disease or even semi-urgent disease, all those patients need to be treated as we do without COVID and with all our emergency treatments, hospitalizations, and in-person visit, while those who are at low risk may be candidates for telemedicine, remote platforms, and delaying or postponing images. So I think that the main point of this document, which has so many important points, is switching from an imaging-based strategy to a cardiac biomarker-based approach in combination of accurate symptoms assessment and deferring the imaging protocols for those who are at higher risk. And there's a number of slides looking at recommendations during, before, during, and after cancer treatment, comparing the ESMO consensus recommendation to the recommendations in the COVID-19 era by ICOS. And essentially, most of them, you see a common theme of obtaining cardiac biomarkers, cardio-oncology evaluation, those who are asymptomatic with negative biomarkers, postpone imaging, those who are symptomatic or with positive biomarkers, repeat biomarkers, have cardio-oncology evaluation for decision-making in troponins. One area that I may like, after we finish this in the next couple of minutes, hear from Dr. Lenihan and others, is some of their proposed algorithms is like, for instance, in these patients who have some evidence for disease by abnormal troponins or symptoms, they're still getting the limited imaging strategy. And for instance, in patients who remain asymptomatic, have less than 50% increase in cardiac biomarkers during monitoring, cardiac imaging not recommended. And this, I would say, is probably, in many cases, at least in our institution, those who are very low risk, we're still very conservative in treatment and try to avoid imaging. But once there's any evidence of disease symptoms or high-risk situation, we, in our practice, still do a significant amount of imaging with all the COVID-19 precautions for patients and caregivers that we've become very familiar and better at as the crisis went by. So the specific recommendations for anthracycline-based therapy is, as mentioned, routine pre-cancer treatment only in those who are high risk, and post-anthracycline therapy and during treatment, try to limit those with either cardiac risk factors, elevated cardiac biomarkers, or need for high doses beyond the doses of 250 milligrams per meter square. Similar algorithm for HER2 therapies, and also for those with combination HER2 and anthracyclines. They generally need more close surveillance. For TKIs, the ICO's recommendation is daily blood pressure monitoring, use of nurse practitioners, minimizing in-person encounters. For the proteasome inhibitors, and most large deal of the work was done by Dr. Lenihan in this field with cardiac biomarkers for assessment of pre-therapy and during cancer therapy. We know there are essential components of cardiac safety in these patients with multiple myeloma and AL amyloidosis. In this case, there wouldn't be any controversy because the utility of cardiac imaging for early detection of cardiovascular disease is not established. So this would be standard practice, probably even in absence of COVID-19. Similarly, for checkpoint inhibitors, the recommendations are for baseline cardiac biomarkers and EKG at baseline, and the need for cardiac imaging prior to initiation of IC therapy is not established and is not recommended. So obviously it should not be done. However, as we know, because the potential high mortality of ICI myocarditis and ICI-related cardiovascular complications, once complications are suspected, the whole spectrum of management with clinical biomarkers, echo, CMR, endomyocardial biopsy should be pursued for our high-risk patients. And also because COVID-19 can present with myocarditis or myocarditis-like presentation, this should always be excluded in the monitoring management of these patients. Similarly, for CAR T cell therapy patients, as we know, these are very high-risk patients. And so for those, it's recommended that screening for COVID-19 prior to initiation of treatment, low threshold for starting anti-IL-6 like tocilizumab in patients who develop CRS, and also consideration that CRS could be from tocilizumab, but also in this pandemic environment, unrecognized co-infection with SARS-CoV-2 should be excluded. Similar for TKIs with vascular toxicity for stroke, MI, PAD, etc. They should undergo their aggressive risk factors modification with use of statins, and also exclusion of coexisting COVID-19 or SARS-CoV-2 that can have similar presentations, virtual consults for all those who are at lower risk. Again, continuation of very aggressive use of cardioprotective strategies for those needed with ACE inhibitors, ARBs, carvedilol, statins, which can overemphasize the significance of very aggressive cardioprotective strategies during the COVID-19 pandemic to reduce the need for potential hospitalizations or additional imaging and exposure. The use of measurements for QT monitoring, QT prolonging agents like ribociclib and many others, with the possibility of doing remote telemetry monitoring for QT in certain cases and scenarios, and the usual measures for electrode derangement and other medications with QT prolonging agents. And finally, the whole spectrum by normal or abnormal troponin and proBNP from the normal asymptomatic with routine care, and if they're symptomatic with everything normal, looking for non-cardiac causes, with a gradient when you start with abnormal BNP but normal troponin. In these patients, trying to repeat cardiac biomarkers, Cardio-Oncology consult, consideration for imaging, particularly if symptomatic, with abnormal troponins, early threshold for consideration for cardioprotective strategies and Cardio-Oncology evaluation, and of course, those who are high risk with both abnormal troponin and proBNP, the whole spectrum with Cardio-Oncology, early consultation, early cardiac imaging, multidisciplinary risk assessment for risk-benefit of continuation of therapy, and early strategies for cardioprotective strategies should be pursued. So in summary, cardio-oncology patients are amongst those at highest risk for complications from COVID-19 because of the impact of both cardiovascular disease and cancer can have a negative impact on morbidity and mortality in this population. As has been previously reported, inflammation, thrombosis, and myocardial injury play a critical role in disease severity of this population. Strategies for surveillance before, during, and after cancer treatment should support limiting testing for those patients at lower risk, particularly in geographic areas of high rates of COVID-19 infection. A cardiac biomarker strategy is preferred over imaging when possible, particularly in lower risk patients. And these modified protocols may have to be revisited in case of a long-standing pandemic, and more data are needed to assess their impact on patient care. Thank you for your attention.
Great, Diego. That was really, really stellar. And I certainly appreciate all your effort at doing your survey. That's a real challenge. So kudos to you for getting that done. The the whole strategy that was recommended in regards to in the presence of an active COVID-19 pandemic really was meant to be a template for any pandemic. So some of the recommendations are based on what we know about COVID-19, but then in general, the other recommendations were applicable to any pandemic, because I think that COVID-19 is obviously the one that's front and center, but there's going to be other infections that we're going to have to deal with, and they're going to have a different cardiovascular signature than COVID-19. But I think that how we take care of our patients in a pandemic-like environment is what the purpose of that document was. So.
Thank you. Yes, absolutely. I think it was an extremely useful document, and as you mentioned, is a good guideline for general care. What we've noticed in our institution, particularly in the early stages of the pandemic, most of cardiovascular services came to a stall. We were doing pretty much 100% virtual, except for emergencies. And after 6 weeks, we gradually went back to full services. And nowadays, our telemedicine went from 100% back. Nowadays, I would say 75 to 80% is in person, and only no more than 25% is telemedicine. On the other hand, in our cancer services, I would say with all the precautions and disruption that the pandemic caused, there was relatively low level of disruption. They never went virtual. In 90% of the cases, they continued to be there, of course, in the cancer center and infusion center, and that didn't change much. So obviously, there's been a difference in impact and in many institutions. I don't know if your experience or anybody else's experience was similar.
Yeah, I would say it was probably generally similar to what you described. And I think that's the purpose of, making a statement that we have the ability to transition from really imaging-based cardiac safety assessments versus biomarkers. So, there have been a number of studies over the past decade or longer that have tried to show some sort of sensitivity and specificity of imaging versus biomarkers. And then depending on which study you talk about, for the most part, I would say that the imaging strategies seem to be a little better. So that's all well and good. But then I think if you try to apply that to a situation in which you're not going to want to do much imaging, then if you relook at all of the biomarker information, you'll see that it would be the negative predictive value of biomarkers is very high. So that means if their biomarkers remain in the normal range or don't change significantly during treatment, they are extremely unlikely to ever develop a cardiovascular event. So in those settings, and that statement could apply not only in anthracyclines, but in HER2-based therapy, multiple myeloma therapy, et cetera, et cetera. If you have negative biomarkers, the chance that you're developing cardiac toxicity is basically zero. So
Right.
you could adopt a completely biomarker-based strategy as long as they remained either normal or just minimally elevated. And so I think that is much more appropriate for a pandemic environment, because as you said, the cancer treatment didn't change. They kept doing it.
Right.
And, you know, all we did is just said, no, we're not going to do imaging right now. So in essence, we were already saying that we're not going to do imaging, but the patients were continuing on their therapy.
No, I agree, and thank you for the comment in terms of the negative predictive value. Some practical roadblock we've found sometimes is when we talk to our oncologists and say you don't need to do imaging, they're a little resistant, and particularly some of the breast oncologists, that they're so set in their protocols that sometimes we really need to go to a certain length to convince them that it's okay not to do it. I don't know if you have similar issues.
No, that's true, but you know, they're operating on, you know, basically FDA recommendations, which the FDA wasn't referring to cancer care during a pandemic. They were talking about cancer care and an affluent, insurance covered population, not, you know, people who have limited access to imaging or have limited funds to do imaging. The FDA doesn't care about that. They just say, what's the best, you know, strategy that we can do in contemporary cancer care. So they say do imaging every 3 months. So, but we as the providers know that we can do things differently than what, you know, major institutions have recommended, and we can probably do them more cost effectively, and certainly I would argue that you can do them in a more safe manner because you're not exposing the patients to the healthcare providers.
So
Absolutely.
first of all, Diego, that was really excellent, wonderful. Dan, I just want to follow and expand what you said. That right now that we're in a sort of a la la land, that we're back to normal to most extent. There's going to be a surge, and we're going to be back to where we were in March and April, probably in the next 4 to 6 weeks. So maybe we should be proactive and go to our oncology colleagues and say, listen, it would really be a good idea, even though you don't usually do this, to get baseline biomarkers on everybody starting therapy, so that we're in a better place if this thing surges than we were 6 months ago.
Absolutely. That's yeah, you're absolutely right.
But I think, you know, the other part that's really important, and you said it several times, but the important part is what cardio-oncology can contribute to the care at the moment. So certainly we can order biomarkers or we can help interpret those. That's one thing. But, you know, if we make sure that people are on appropriate cardioprotective therapy and they take their statin and, you know, they do all the things, they check their blood pressure, all that kind of stuff, you know, oncologists can't do that because they've got way too much to do. You know, they got to go over the CT scan and talk about the pathology and whatever, and make a decision about which drugs they want to use. So we can support these patients by doing good cardio-oncology care that doesn't necessarily involve imaging. It involves being a good doctor.
Yeah, so the other thing we can do is make sure everybody we see has a 90-day supply of everything that they take.
Absolutely. Yeah, I agree. Both were great comments.
Yeah, I don't know. There are lots of people listening. I don't know if they have any questions.
Thank you
Yes.
for an active presentation. I have a question. As you know, cardiac biomarker elevated when you have cardiac damage and return to the normal after 3 months or 6 months. It's returned to the normal. Is it still preferred over the imaging?
I'm not sure again. So if patients who had normal biomarkers after 3 and 6 months, if they still need biomarkers opposed to imaging, is that the question?
Yes.
Yeah, well, I guess, and then I'll see what's, what are Dr. Lenia and Carver's and others' opinions. In my opinion, obviously, if the patient, it depends on many issues. Obviously, we're talking about a low-risk patient, asymptomatic with no cardiac risk factors and negative biomarkers. Repetitively, there's probably no indication for imaging, at least during the pandemic. The issue would be if they are in a high-risk group or their biomarkers are positive, or if they have unexplained symptoms. That's where we would probably have a lower threshold to consider imaging. So, but if everything is negative, they're asymptomatic and negative biomarkers, it's probably safe to continue without additional imaging.
Yeah, I mean, I would
Thank
agree
you.
generally. Yeah, generally with what you're saying. I think the other piece besides, optimal therapy in whatever form that is accurate assessment of the symptoms. Because, I can certainly pull out a number of different studies over the years where a patient who's undergoing therapy for their cancer, they're going to have, fatigue and dyspnea and all that, may just be attributed to either their underlying cancer or the treatment they're receiving, and not necessarily indicate heart failure. So I think that the cardio-oncology role is not only to optimize their medications, but would be to accurately discern whether there's significant cardiac symptoms present or not. Because, if you ask a patient who has cancer if they're feeling bad, for the most part, they're gonna say no because they want to get their chemo. And I mean, I can cite many examples and many studies that have shown that discernment of symptoms, cardiac symptoms, is not very good during the course of cancer therapy. So I think that's where we can really, assist in the management of these patients.
Excuse me. Would you please show the anthracycline slide again?
The anthracycline?
Yes.
All right.
I think some slide before.
No. This one?
Thank you. Yes, thank you so much. I just want to see it again. Thanks. Fantastic presentation. Thanks a lot.
You're welcome.
Great, thank you so much, Diego. Really fantastic, and we appreciate all your effort, not only for this presentation, but for all your efforts otherwise. We really, I really think that's a truly wonderful survey and other efforts that you've made to try to bring people together. So it's really great.
All right. Thank you, Dan, and thank you all, and thank you for the invitation and opportunity to talk today. Thank you, guys.
Hi, Diego. Can I ask you a question before
Sure.
presentation is over? Thank you so much. That was a fantastic presentation. I'm a hospitalist, oncology hospitalist, taking care of oncology patients, and I am also part of the COVID team. So I'm an attending physician at Rutgers University. So I had a pretty extensive experience with COVID oncology patients. I was personally coming across so many patients who were already, sorry, I was disconnected. So they were already on all the cardioprotective medications, including statins and beta blockers and ACE inhibitors. They were coming to the hospital, they were admitted for COVID, and then of course their biomarkers were going up, their troponin was trending up. And we were like questioning, they were already on aspirin and a statin, so we were thinking, should we start them on the dual antiplatelet therapy on top of the anticoagulation they were getting? Because you know that a lot of these oncology patients are also having this pancytopenias and thrombocytopenias, and they're also at the risk of bleeding. So what is your recommendation? I'm not talking about a STEMI or non-STEMI with a very elevated troponin. I'm talking about like a minimally trending up troponins in those patients who are already on some cardioprotective medications, but we want to optimize them. Should we go with the second line of antiplatelet therapy on top of the full anticoagulation we give for COVID patients, or you just suggest to continue with the same aspirin and anticoagulation only?
Yeah, I'm not sure if there's data, or I'm not familiar with any data comparing heparin and aspirin versus heparin and dual antiplatelet therapy in COVID-19 patients. So again, I guess that would be an individual decision. I don't think there's a lot of data to support such a strategy. In general, I would probably, and most of us would take the same approach when dealing with high-risk patients. If it's a patient with multiple previous vascular events and strokes and severe CID, then we'd be extremely aggressive with our antiplatelet therapy and anticoagulation and statins, versus those with a lesser baseline cardiac risk and higher bleeding risk, then we would back off a little more holistic approach. In terms of clinical trials, comparing those two strategies in the COVID population, I'm not familiar with such data set. I don't know if Dan or anybody else has any comments.
Yeah, I mean, I think this is a really difficult area, so you're gonna have to personalize it to what you see in that individual patient, but also kind of what your institution is comfortable with. But generally speaking, because there's a lot of thrombogenic processes that are happening in people that are COVID positive, that at a minimum, if they were on aspirin already and you saw minimal troponin elevations, I probably would consider, heparin or
oh yeah, no,
some other anticoagulant. But
definitely,
yeah.
Definitely, the question was on top of aspirin and heparin, if we would add dual antiplatelet therapy. No, we do aspirin and heparin in those patients. The question was if on top of that, we would add a second antiplatelet drug, and that's where I think we don't have data.
I would agree. We don't. That's probably going to be too aggressive.
Yeah.
Okay, thank you so much.
Yeah, very good. Thank you so much, Diego, and we really appreciate it. And we'll be here next week, same time.
All right. Thank you so much.
See you later.
Take care, guys. Bye-bye. Thank you. Bye-bye.
Thank you. Thank you, Diego.
Thank you, Steve. Thanks for everything.
Thank you.
Bye-bye.